non-invasive radiation-free manner. Geetha holds a PhD from IISc and management education from Kellogg's, Chicago. She comes with over 25 years of experience in IT innovation. She has proposed and led multiple AI projects at Xerox Research and Hewlett Packard India. Before starting Niramai, Geetha was a lab director for data analytics research at Xerox India. Geetha has received many international and national recognition for her innovations and entrepreneurial work, including CSI Gold Medal, BIRAC Winner Award 2018, and is also on the Forbes list of top 20 self-made women this year. I'm very glad she's agreed to give this lecture in our college to our research group in CIT. She is also an inventor of 16 US patents and more pending grants. She was recently awarded the Accenture Varney Innovator of the Year award from Economic Times. She was also involved with building of India's first supercomputer, Param, when she was with CDAC. I'm very happy that she agreed to give this talk to us, and I'm sure it will be motivating, it will be useful for a lot of our faculty and audience who are here. Thank you, Geetha, again, and please start your lecture. I don't want to waste too much time on other things, so please, we are eagerly waiting for your talk. Welcome, Geetha.
Thank you very much, Professor Pradeep, for the invitation, and thank you, Mr. Girish, and the whole team for arranging this. And it's really wonderful to meet all the faculty and researchers who are actually creating the future of India. That's how I think about it. And thanks for coming over here Saturday morning to hear about some of the learnings that I've had in the last few years. I'm assuming that you're able to see the slides that I'm sharing.
Yes, madam.
Okay, thank you. So, it was, introduced, I'm the CEO and CTO of Niramai. Niramai is a startup that we started 3.5 years ago, and it stands for being healthy. Sarve Santu Niramayaha, let everyone be healthy. That's our motto, and you would have heard this from the Rig Vedas, right? And it also has an expansion, non-invasive risk assessment through machine artificial intelligence. So the key mission of this startup, which is almost like a company now, is to use AI, artificial intelligence, to non-invasively detect health risks. And why is this important and how is it possible is what I'm going to talk about in the next 45 minutes. And I'll be happy to take any questions in the middle or at the end. Feel free to interrupt me. So first of all, I think this particular group will not need any introduction to AI as such. Still, just sort of to do justice to the title, AI is artificial intelligence, that is data-based decision-making. Wherever you have a task done by a software program, which requires intelligence for a human being to perform, that can be called as artificial intelligence. But there are several definitions. We can just stick to that, right? And artificial intelligence is actually making inroads and creating several interesting applications in different domains. And it's become almost like part of our life in many ways. And many of you would have used Ola, Uber, and all of these, which do have AI at the back. So many other things. I mean, you can think about anything around you and there will be an AI right now. Now, the last domain that is almost last domain that is getting affected or impacted by AI happens to be healthcare. And because, healthcare is almost like a mission critical kind of an application where if there is a tool or anything that is, making a difference there, it better be as accurate or even more accurate than the doctor herself or himself. This is important because the doctor is working with real life of people and it has to be really, really high quality, high performing. So when we say artificial intelligence in medical diagnosis or medical imaging, we are talking about really high accuracy AI algorithms. And it's also very nice to see that, yes, we are seeing many, many applications in this domain, which shows that the technology has evolved to actually even help in this, the most life critical domain. Among all other applications of AI in healthcare per se, when we look at AI, which is impacting clinical diagnosis, these are called clinical decision support systems, CDSs, and that's one of the important parts which we will look at today. And among these CDSs, for example, a CDSs could be looking at all your data, maybe your wearable devices or what you have in EMR, electronic medical records, and all other data. There's so much data in healthcare. And so using all of the data, it can actually predict future, possibility of a future disease that is going to come or any such things, right? So you would have seen many, many applications. What we are going to focus more on today is a part of this, which is called medical imaging based. And we'll also see why this is interesting. First of all, many of you would have seen at least one medical image in your life. Many of us have taken chest x-rays, broken our hand, legs, and taken a, x-ray of the different parts of the body. There's also CT scan, which is also x-ray based and so on. So all of these form medical image. In fact, it is not just that. There are several machines from different healthcare vendors like Philips, Siemens, Hologic, many, many people who are coming up with these complex devices which can image the body. Why is this needed? It's needed because let's say you have a person in front of you, the doctor is seeing a patient. The best thing is if he's able to see the problems that the patient has. Obviously, you're not able to see, right? Of course, if it's a wound or something, you can correct it. Let's say the person has cancer, because that's my area of specialization. The only way to figure out whether he or she has cancer or not is to actually pick up some cells from the lesion, from the lump, and put it under a microscope and see this. How can we do this? How can we go on poking people to figure out if somebody has cancer? That is impossible, right? So we need an alternate proxy for figuring out what is inside the body. That is where the medical imaging helps. So what it is trying to do is to look at different spectrum of the electromagnetic spectrum, different bands of this, to actually look into the body as much as possible with different views. What I mean by views is, let's say an X-ray gives you density variations. A thermal image gives you temperature variations. An ultrasound gives you texture variations. Like that, right? So different tools and methodologies and modalities used in medical imaging, all of these machines here, are trying to look into the body using imaging. So how does it help? It helps because a person standing in can go through an imaging, and we try to avoid poking people as much as possible. We try to avoid invasive procedures. And so these equipments need to provide highly accurate, high resolution images so that doctors can take a look at it and figure out if something is normal or abnormal. Obviously, they would be trained to figure out what is normal, and so they can look at things which look abnormal. So that is how traditionally it has been done. Now, there is a problem because we need very, very high levels of accuracy, because only if a person is found to be abnormal in a medical image, the person goes for a histopath test. That is basically a tissue test, which is where the person will be known whether she or he has cancer or not. That means this imaging should never miss a case, right? If this imaging misses a case, then the lady goes home and she will never be able to find cancer or any other diseases. And we'll see why it's important to find early. The specialization in medical science, which the doctors who are experts in looking at these images and then saying whether something is wrong or not, are called radiologists. And of course, many of you know about this. And there are very, very few radiologists who are really expert in just looking at an image and saying whether something is wrong or not. Especially in India, where we have one doctor serving 1,000 villages. Clearly, we're not talking about rural areas. Even in urban areas, there is a sheer shortage of expert radiologists, and radiologists are experts, and so they're also pretty expensive to sort of, hire to, let's say for a diagnostic center or any other, even a small hospital. Wherever there is a radiologist in an expert hospital, he has many patients, many x-rays to, I know radiologists who review like 1,000 x-rays per hour. It's crazy. One, because the x-rays or MRI or CT scan that we're talking about can have very small and minute abnormalities. So it's not like you just look at it and you get the answer, right? You get the abnormality. You really have to focus on different elements of this to figure out if there is a small problem, and then start looking at it. And then try and see if there is a treatment that needs to be given. So in order to make that happen, AI, as you know, can actually do these things very well and help the doctor as a tool to increase his productivity. That is, more number of scans can be done with better diagnostic accuracy. And most of all, we have to lower the rate of misdiagnosis, that is, missing a case. Even if you get a few extra, that's fine, right? Because she, let's say in the cancer case, she can actually go for histopathology or a tissue test. And then if that is negative, she's happy and she can go back home. At the end of the day, all we want to do is, using this imaging, medical imaging, we want to improve patient outcomes. What does it mean? Having more people healthier, which means that, let's say, if you detect early, the treatment costs are lower, the treatment efficacy is better, that she'll actually get better faster, as well as the quality of life after the surgery is also better. So this is true for all of the diseases, and particularly true for what's called as NCD, non-communicable diseases, which is, mostly cardiovascular, diabetes, and cancer. At the end of the day, we are trying to save lives using imaging. And coming back to AI, and we know that AI loves visual patterns. AI is very good in trying to work on visual and audio data. And that's also very recent. And many of you would have heard about deep networks and deep learning, deep networks, and so on. And these deep networks are more suitable for visual patterns, right? So pattern-based. So this is what we're going to look at. And because personally, though I've worked on several other things, so last 6 years or so, I've been focusing on one of the biggest problems in women's health today, which is breast cancer. And breast cancer is definitely the leading cause of cancer deaths, with over 500,000 women dying every year. Actually, it was 624,000 last year. So many people dying. And in India, 90,000 women died last year, which is almost 15% of the global death. The unfortunate thing is that this is one of the most curable cancers. Nobody needs to die of breast cancer. Still, we are losing 600,000 women every year. This is actually almost reaching the COVID deaths that we have seen, I think. And this is every year we are losing for the last so many years. And that's what we wanted to stop. And what is also further unfortunate is, while we can have 90–95% survival rates in, let's say, in US, UK, and other places, developed worlds, in developing country like India, this survival rate is 50–60%. That is, every alternate lady is losing her life whenever she gets breast cancer, which is crazy, right? Because you can save 90% of the ladies, we are losing 50% of the ladies. All this is because of late detection. Early detection is very, very key for survival. Why am I saying this? Please listen on, and we will see how AI can help this. That is the story. So let's see why early detection is not happening. There are several methods today, right? Some of you may be aware, some of you may not be aware that there is a tool called mammography. We saw many x-rays. This is x-ray of the breast. Don't feel shy, breast is also yet another organ, just like hand. And if it is killing 600,000 women, we better be conscious that it's just an organ, right? And so this is an x-ray of breast, where it's trying to find lumps, small lumps called microcalcifications, which will come out as white. And the radiologist is looking for this special looking, abnormal looking white spots. This is a 60-year-old. It's kind of possible to find. This is a 40-year-old, the whole breast appears white, and you cannot, even the expert of the expert radiologist is not able to find out the cancer is here. That's a huge limitation. This is called dense breast tissue. And this is because of fibroglandular tissue. It could be just the make of the person and so on and so forth. However, almost all women under 45 years of age fall in this area. And the mean age of cancer detection in India is 50 years. Most of the people who are getting breast cancer are under 50 years and they're finding by hand. They are not able to use this tool. And also 50% of the ladies above 45 years are also dense breast, and they're also detecting very, very late. If a lady finds it by her hand accidentally, the cancer will be 25 millimeters in size. Otherwise, it will not be palpable by hand, which is stage 3 or stage 4. Stage 3, stage 4 survival rate is actually 5%. Stage 0, stage 1 is 95%. That is how fast the cancer grows, and that is how important it is to actually detect stage 0, stage 1. Now, mammography is good. It can catch a 5 millimeter cancer, which is wonderful, stage 1. But it is not affordable. It's a 3,500 rupees test. How many of us would go every year and get this test done when we don't have any cancer, when there is no symptom? This is for regular check. That's what is important for early detection. And also, very few hospitals, I'm not even sure if Gubbi has a mammogram in the whole of the town. Very, very few tier 2, tier 3 cities would have a mammography machine, because a mammography machine costs 80 lakhs to 1 crore. Which hospital, which diagnostic center would put this in for just some part of ladies who may actually want to do it? So this is one. And finally, another big thing is that it uses X-rays. How can you use X-rays to detect cancer? X-ray can increase radiation exposure and increase the risk to cancer. All this results in almost 90% of the ladies finding the cancer by hand, and almost towards the end. And if they're lucky, 50% of the time they actually survive. That's a very, very bad situation. So let's see how AI can help, because this is all about data. This is all about visual. This is all about patterns. So let's start with mammography. Let's say we have these two kind of images. Can we do AI on this? So many guys looked at it. Many researchers looked at it. Even Google looked at it. And in January, they actually published a wonderful paper. They used deep learning to try and figure out abnormal patterns, abnormal specks, we call it, in this whole image. They were able to, this is comparing to nine radiologists, expert radiologists on one side, and the AI machine on the other side. And the 9 radiologists gave different answers of where the problem is and whether there is a problem is there or not, right? So then usually you do what? You do the majority voting, right? That's the ensemble learning. Some of you would have heard about it. So with that, the study showed that it could reduce false negatives. That is, falsely calling as negative means missing cancers, right? False negatives were reduced by 9.4%, whereas false positives was reduced by 5.7%. It's pretty good. Actually, this actually improved, and it also showed that even the US doctors are not good enough, right, for solving this problem. But the problem is much, much higher. What we looked at was this kind of density, but there are many women like this. This is called 4 categories. And it gets more and more complex as the density actually increases. How do you actually find it in any of these places? So this is the problem. We started off as Niramai, and we said, okay, what can we do? And in fact, I actually lost 2 of my cousin sisters for this particular disease, and that's where I quit my job and started this startup. And we said, okay, let's not use X-rays, because X-rays has this physics limitation that density differences are not able to figure out whether there is a problem. So we started with a completely different modality or imaging modality called thermography, which is also called infrared imaging. Basically, it's a camera, it's a sensor which looks at the infrared spectrum. Okay. So here, there was earlier literature which talked about use of this for detecting breast cancer. And so we sort of studied that and said, what's happening? So what happens is when there is a cancer, it's dividing at a much abnormal rate. We all know, right? Cancer cells are hungry to sort of multiply. They don't die. So most cells die and sort of, more new cells come in and old cells die. And that's the nature of the whole body, right? And different parts of the body have different rates of growing and dying and all that. So this is a normal part of the body. Now, whereas when it is cancer, it only grows. I mean, it only multiplies, it stops dying. So that is another main problem. And it also starts eating up the resources from the rest of the tissue. So all this higher metabolism in the area and also higher nitrogen oxide results in an increased temperature at the tumor region and a thermal pattern around it, which starts looking abnormal. And that's what doctors, of old times, even in 1970s, there was one instance of somebody looking at a thermal image to see if there is a problem. And the idea is to look at left and right side and see if one of them has a higher red than red. Of course, this is a heat map. So many of us have done physics. So if you want to look at multiple temperature data or any data in a spatial manner, more so, you can look at it like a heat map where every temperature value, every value, real number, or as a range of real numbers is given a color. So in this particular thing, you can say that white is 37 degrees Celsius, red is 36, orange is 35, something like that, right? You're actually looking at 400,000 temperature points on the body, right? This is a high resolution thermal sensor which can give this. And now the doctor is trying to make a decision of whether there is cancer or not. Sometimes, if stage 4, stage 5, it's very easy to find, but sometimes, you have a red all over the place, and obviously this is not cancer all over the place. So there's a lot of interpretation errors. And when initially it was started, it was created a lot of good vibes, but then later they saw that they were actually calling many people as, falsely positive. For example, when we do the screening, and we've done a lot of screening, out of 100 people, if you find 60 people having a red spot, but that doesn't mean all 60 are cancerous, only 0.6% would be cancerous. So how do we reduce these false positives? And when you want to try to reduce this false positive with manual interpretation, you end up calling people who are cancerous also as non-cancerous, especially early stage. So all this resulted in a havoc, and they said, okay, don't use thermography alone. You can use it if you want it along with mammography. So this is what US FDA said. So that is where we come in, and then we said, can we use AI for it? And we've designed this new technique called thermal analytics, which is basically machine learning on these thermal images. Simplistically there are a bunch of thermal images. It passes through our trained machine learning model, and out comes a complete report or a diagnosis saying whether she's cancerous or not. Is it possible? And that's what we will talk about. And this is very unique. Nobody else in this world has done it, and we have 10 US patents on it. So the basic idea is the same thermal sensor is taken. You take these images and then pass it to the machine learning model. So just one last slide about the context, and then we go into the initial, how it works and so on and so forth. So with this, what happens is just the advantages of doing this, right? First and foremost, I told that most women detect cancer by hand, which is at 25 millimeters in size, and we are able to detect as small as 4 millimeters or 5 millimeters of cancer, which is stage 0 by definition. And of course, it depends on when the person comes in front of the test. So depending upon what stage it is, we are able to detect, of course, a stage 5 cancer as well, a stage 4, sorry. What is very probably interesting to women in this audience is that it's completely non-contact, non-invasive. For mammography, the breast is put under 2 plates and sort of somebody else is there touching and pulling and all of that. It's such a horrible experience. Whereas what we do is no see, no touch. Not even a technician is seeing you or touching you. You just get into a booth, sit in front of a device for 10 to 15 minutes and come out, the report will be ready. Nobody would have seen you or touched you. Of course, there is a disrobing on the top that is required, but it's like a changing room experience. You just close the door and go inside. So this is the only test which actually provides this kind of a privacy-aware screening, which is most important for this particular test, especially when we talk about screening. If there is a stage 5 cancer, of course, people want to live and they don't mind, right? Going to a hospital and so on and so forth. And it's no radiation. It is just measuring the temperature on the skin, no X-ray, nothing. So it actually has absolutely 0 side effects. and it does work on women under 45, above 45. It works for men too. Men also can get breast cancer. Many of them are not aware. 1 in 1,000 men actually can get breast cancer. We ourselves have screened 25 to 40, 50 men with this, abnormal men with our solution so far. And unfortunately, we have found a 17-year-old girl with cancer, many 21 and 30 year olds, especially when they have family cancer history and all that. So it does work for men of all ages, and we made it very, very affordable. The cost of the device itself is 1/20th the cost of a mammogram machine. So many hospitals and diagnostic centers and villages can also have it. As well as we made it very portable. It's just like a 1-liter water bottle. You can put it in a backpack and also do camps. So the idea is this is basically an AI-based computer-aided diagnostics. We call it CAD, right? Not the CAD. It's the drawing part, but this is basically a diagnostics part where the images come in. All of these models are used to generate a report. So we have, the report is very nice. Now we have scores. So many of you who've done machine learning will know that there is a likelihood ratio, likelihood probability, which gives you the probability that the person belongs to the class malignant or class benign. So that gives you a confidence of the algorithm on whether the person is malignant or not. So these scores actually are also given. In villages, we directly give a red, yellow, green because there's no doctor to review these scores or whatever. And also automatically generate these images where the markings are automatically done. The markings indicate the area of abnormality. And this is how it looks. A small device, a small device here, which basically it's an off-the-shelf device. You would have seen this in airports and so on. It's just the same thing. And simply skilled women like health workers can actually do this, which means that it is scalable. We've done it. We've actually installed in 60+ hospitals in 15 cities today. And recently also announced a partnership with Apollo Clinics. Now it's like more than 100, I guess. And so we've also done many camps like this. A small booth is created. The lady is inside, the technician is outside. This privacy awareness is very important. We also have it in buses. We've done more than 1,000 outreach camps, many of them free for the end users. So the last thing, and then I the machine learning part, just experience of how. Okay, so what is the innovation? So what is the problem, right? And how are we going to sort of solve this, right? That's the underhood part we will talk about. So the problem, there are 4 images here of 4 different people. The first one is a normal patient. The second one is a person with cancer. The problem is here. And these 2 are not actually malignant. But then you see that there are lots of red spots here. So now what happens when you actually visually do this is only this person is called out as normal and all the 3 come out as positive. And that's where the 60% false positive comes in, as I mentioned before. So now what we do is we have a machine learning algorithm which uses where we have actually used both statistical data as well as specific domain dependent data. So when we actually started off, there is no data set which basically says, here is the sort of set of images and here are the class labels, right? I'm assuming most of you are aware of machine learning. Machine learning, what happens, there are 2 main phases. First is a training phase where you train the machine learning model with a set of samples. This is called supervised learning, part of supervised learning, where you give the images or give the data along with a class label. What are the classes here? Let's say cancer, no cancer. So you ideally give a bunch of images, and for every image you say whether the person is cancer, has cancer or no cancer. And then the model, the machine learning model, has to tune itself, configure itself to start learning this decision process. To say that when an unseen data is coming, a new image is coming, it's able to say whether it is cancer or not. That's the sort of the basic part, right? So now what is the problem and what are the features? How are we going to get these features? How are we going to train this model? And that's where the crux of the matter is, right? So when we started off with, there is no such thing. There is no such group of images or nothing. So we had to actually collaborate with hospitals to start collecting this data. And then we said, okay, typically like you saw in the Google case, you have these mammography images, millions of them available along with doctors, final guidance or final observation is available in the world today. I mean, you can Google and then MIS data, DDSM data, all of this, you can actually try it, that there are labels already available. Now, unlike that, here we do not have any thermographer who can do a good job, because if they were doing it, this method would be there everywhere. So what we did was to take all these images, or rather we asked people to take thermal imaging, that we ourselves do the thermal imaging for the person and make the person go to mammography, ultrasound, and then biopsy if she's positive, and take the biopsy data, off-channel actual label, and then train this. So you can imagine, right? So we had to start with very small set of training data to actually start building the model. So what we started doing was to look at statistical patterns, obviously. In addition, are there any semantically visible patterns? Are there some medical features, medical reasons why a pattern may look in a particular way? I'll give you an example. One, asymmetry. Most people get cancer in one breast, and unfortunate, if she is unfortunate, it can recur in the other breast, maybe after 3 years. So that means the initial one would be actually one side problematic. So asymmetry is a big, guidance that we can use. How do we specify this asymmetry? Here also there are asymmetrical patterns. So we have about 32 different ways, statistical ways of signifying or representing these asymmetric patterns. Then how is the thermal distribution itself, is what's called a focal increase in temperature and so on. And another big piece that we had to do was to, what happens if the cancer is very close to the chest wall, very deep within? It doesn't come on the skin. What infrared cameras measure is only the skin temperature, but you need to find the cancer wherever it is. So we developed a method for identifying blood vessel structures. That is basically using image processing and method called Franga index based model, where you can figure out that there is, let's say, no temperature variation and a high temperature variation with a clear boundary of the intensity going up like this, right? Can you see? So that was used to figure out tube-like structures. And this tube-like structures and vascularity analysis is also done for diabetic retinopathy, actually, if you see. Right, several places where you want to analyze the blood vessel activity, you can actually try to extract tube-like structures. And once you do that, we actually analyze these tube-like structures in a symmetry or non-symmetry part. Again, a 30 plus or whatever number of additional features came in. And then there are boundary-related features, because cancer cells are very irregular and aggressive. You have jagged edges. It's called speculated margins. So that gives you a lot. So many of these features, which are driven by semantics, driven by medical science, but statistically represented in an image processing fashion, were actually used. And you will see how, you are from here. And so there are many such. I'm just showing one such machine learning model, which is for the final classification of saying whether it's a cancer or no cancer. It's called a binary classification, right? You can have multi-class classification, binary classification. So I'm talking about this last one. Now, when we gave this tool to people for trying out, of course, first few, we were only doing many thousands. We ourselves went to the villages and did all the screening. However, obviously, we can't be anywhere. So we had everywhere. So we actually had to train people. When we started doing it, they made a lot of mistakes. There are 5 views instead of left. They were right, naming it as right and so on. So we had to come up with machine learning algorithms which can help the end user, help the health worker, do the screening correctly by guiding the person as and when she was actually doing the screening. So this is different ways machine learning can be used. We said, okay, can we tell whether the person is left or right just looking at the contour of the body? And that was using a deep learning model. And if time permits, I'll go through that model a little bit more. And several such things. And then once you have an image, so you need to figure out what aspect of it needs to be analyze. It's called segmentation of region of interest, and that whether it's a underarm that's a problematic thing or the breast itself. So you need to do the breast segmentation. And then we need to find out where is the hot spot. It's not that anything above 32 degrees Celsius is hot or anything like that. You know, for different people have different body structures and different temperature variations. So it has to be a decision rule within the body of the person, relative temperature rather than absolute temperature variations. So that is another big thing. And then several other things like feature engineering as well, and feature learning as well. And finally, the classification. And so this whole thing has about 10 to 15 such machine learning models. So that you can have the end-to-end solution where a person can go into a hospital, sit in front of a hospital or actually a rural area, and come out, and a health worker will be able to generate a report. And we are able to do that, right? So I'm just going into a few more things. Yes, I do have 15 minutes more. So here is an example, the first two cases. Bear with me for the images. It's perfectly fine. It's just the body. So what we're talking about is the 5 views of the person, like this, what you can say, frontal, left 45, left 90, right 45, right 90. So we first said, okay, let's look at the body contours and then do a traditional image processing based approach. And we got 75% accuracy of tagging or view labeling, we call it, saying what view it is. Then we used a ResNet 50 architecture, which was trained using an RGB, normal image, normal video and normal imaging. And then we fed this, because that has a pre-trained network, and then you feed a smaller sample size into it to say what is left, what is right? And then with a 5-class classification, we are able to get even up to 97% accuracy. So now if a health worker makes an error, we say, I think you've called left as right, and she can actually take a relook at it and then modify. Okay, and this is important because when we are doing the stitching of the 3 views, right, the 180 degrees view needs to be taken, stitching of the 3 views, it will cause a lot of havoc if right and left are, misrepresented. So almost like 24% or 22% additional accuracy was given because of deep learning. Yes, deep learning really works on images, but you need to have sufficient. We actually needed to have about 5,000 to 25,000 images, before we even started working on deep nets of this nature. The other thing was that you have this whole image, you have to mark the area of interest. Here it's the breast region. So if we looked at this space, and then we looked at image processing base, and we got 75% accuracy. Then again, we went to deep learning here. Some of you have done deep learning would know that, the U-nets and V-nets are very good, where the input is an image and output is also an image, maybe a different tagging of an image, an annotated image, or whatever. So we used a V-net, what you see in the second one, as a method of training unmarked image and marked images output. What's called annotated image is the output. Then if you just have 10,000 images, that's not sufficient. So we said, okay, there are different ways of what you call as you do data augmentation. That is, you have a training set, you can augment the data to make it bigger and bigger so that the deep learning network can actually learn with more data and also can generalize, right? For example, the usual methods of augmentation are, rotation invariance, scale invariance we talk about, right? Same way, you actually scale it, rotate it, and, create additional pseudo data, you could say, right? And then do the data augmentation. So here again, obviously we did all that. We also did flipping, right? Because all the left. So it basically always marks the left side, right? And then you can always flip back if you have flipped and those kinds of things. So we actually use the view tagging to figure out whether it's a left and right. And if it is right, flip it to the left and always feed. And this is a new thought process. I'm sharing the details because you may want to use some similar ideas in your own problems, right? The idea is to sort of try and see how the same things can be applied to yours. So the results were like, phenomenally good. So you can see the yellow ones, which basically came like this, and with deep learning, we were able to get up to 99%, tagging as well. So the final stage was obviously, I was talking about the training phase and the prediction phase. So the input comes in. It's all clean and nice because we've done all the image quality check and, analyzed. And so only the breast region is fed in here. And initially, as I mentioned before, the labels came from the biopsy of the same person, right? Where person came in because she had a problem, maybe late stage problem. We went through the full process to treat her. The doctor did that very well. And we took the final ground. But just before she did a mammogram, we did a thermal imaging. And this requires a process called clinical trial process. Happy to talk about it if anyone is interested in healthcare of AI. And then, so this label is taken in and, we extract the features that we mentioned, all the list of features I had talked about, features get into a machine learning model. We tried many machine learning models. Those of you who have tried supervised learning, you'll know SVM is wonderful, right? That's one usually. But actually, we found random forest to be super good. Random forest is a bunch of decision trees, right? So we found that to be pretty good because it also kind of explains. What do you mean by explainability? So when you give the output, in a report and say she's cancerous, the doctor can't say to the patient that machine learning said yes, so you have cancer. No, it has to be explainable, and this is another big topic. If those of you want to do research, you should take this topic into consideration: explainability of machine learning models, particularly deep learning models, where the features are learned automatically as well. We don't have extracted features like this in deep learning, as many of you may know. So when we want to explain this, right, you can look at what feature contributed to what aspect of the result itself. So we actually came up with an idea of finding out not the correlation, but impact of a feature onto this. Many times, some of you would know about the PCA, principal component analysis, where you will say if you have thousands of features, you can figure out which are the top 10 features that are impacting the decision, right? So that is one way of doing it. But you can go into the further details and say, what is the impact of each feature? For example, when we did this, we now generate a report saying irregularity 9, hotspot boundary 2. So this shows what is the impact on that means because it's very irregular, we are saying it is cancerous. Because the hotspot, distance is not, what extent we call it, extent is small, we are saying it may not be. So this reasoning will help the doctor to actually explain and also trust the answer. Finally, when a new person comes in, the input is taken, there's no label obviously, and the label is predicted. So with this, we were able to so far do about 33,000 patients screening. Not everybody is cancerous, be it in villages screening or town or hospitals, or also clinical trials. Clinical trials are something like training that we did, but it's completely blinded. It's like a final examination, right? You go, you do the test, somebody else will do the test on thermalytics test, and the tool automatically generates a result. And the same person goes through mammography, ultrasound, and biopsy, and the final results are compared. We do not know the answer key till a third person, like an examiner, comes in and checks. And this kinds of clinical validation is absolutely critical when you are trying to take this to market, right? To actually screen people. So the largest one we've done is on 769 patients, where we got really 100% sensitivity on women without symptoms, and overall 92% sensitivity, which means ability to detect. Okay. For healthcare, you do not use the word accuracy because there is a lot of imbalance in data. What we mean by imbalance in data is one class has much higher possibility of occurrence rather than the other. That is prior probability. For cancer is 0.6%. Out of 100, 0.6 people can have cancer. So which is in a generic population, I'm saying. So in that sense, it is really really biased towards one side. So then, let's say out of 100, 4 people have cancer. That's also another metric we generally see in urban population. So with this, you can have a 96% accurate test when you just say no for everybody, because you would have missed only those 4 cases, right? So accuracy is not a metric used in healthcare. We use what is called as sensitivity and specificity. Sensitivity looks at only positive cases and says how many of them did you get, and specificity looks at only negative cases and say how many of them you actually called it as negative. So both have to be 100% if possible, but no doctor is also as accurate as that, and so we have actually reached this. And we've also got much better accuracy than mammography, where we got 100%, mammography was 67%, and that's the standard of care around the world today. And so doctors are also pretty happy that these are performing well. And also almost 250 patients could not even go through mammography. So this is on 400 patients and this is on 769. So it's like, and this was also selected in multiple, I mean, this particular one was selected as a top abstracts in ASCO. And we have several journal papers also. If people interested can look at the top tier papers. Of course, the Niramai team has received a lot of awards. And I'm very proud to say that, in the list of top 100 AI startups in the world, Niramai was responsible or has been able to put India on the AI world map. It's the only Indian startup listed on the top 100 AI startups in the world. Thank you very much. Hope this was useful to some extent, and happy to take any questions.
Thank you, ma'am. Is there any questions from the participants side?
Good morning, ma'am.
Yeah,
my question is on if a patient has other hypertension or other conditions, so will there is any change? Hello, am I audible, ma'am?
Yeah.
So if a patient
yes,
has any other hypertension or any other condition, will there be any changes in the heat map of an image? And how it is taken care by artificial intelligence, ma'am?
Yeah, good question. So clearly, body is such a complex matter, right? I mean, object. You can't take all, features or everything on the body. Yes, of course. And then you say, okay, which of them really matter and so on, because otherwise you start feeding in noise as well. And so what we generally do, we have to study medical literature. So this is another big topic of AI versus whether AI needs the domain knowledge or not. Healthcare, definitely, I think it requires domain knowledge. There are volumes of medical literature available in this particular area, right? For many diseases, right? So what you need to do is also spend some time and figure out which are the most commonly affecting demographic information, patient information that matters to the cancer risk, right? And then intervene. Particularly in our case, family cancer history, hormonal positive or not, last menstrual cycle, whether she's menopause or not menopause, all of these have been proven to have a significance on the person. So only those you need to take. BP is not part of that. Whereas a genetic BRCA mutation is. So if a person has had a genetic test, which is very rare in India, if that information is available, right? So you need to study the disease and then figure out what are the actual possible causes of impact on risk, or rather what features will impact risk, and only those you can model, and we do that as well. Good question.
Thank you, ma'am. And also one more question. Do we have access of that particular images, ma'am, image data set?
Madam, no, ma'am. I can't do it like that. Also, it is bound by the privacy for the end user, right? Whenever we do the imaging, we will not share it with anybody, right? And that's when they will actually do this. Having said that, there are some data sets like Brazil data set which don't have a real good labels available. But you could start with mammography, or we can figure out if there is real interest, we can figure out a way of working with you.
Okay, thank you, madam. Thank you.
Any other questions from participants?
Hello.
Yeah, go ahead. Good morning, ma'am. Actually, between the age of 40 to 45, usually the patients will get tumors or cyst, what you mentioned in one of the image. So actually identifying whether it is a cyst or a cancerous one, it's a really challenging no. So at that time, even though it is a non-cancerous, so make the patients to go for biopsy. Even if the biopsy also, if it is not accurate, sometimes they'll do the surgery just to identify whether it is a malignant one or a benign one. So how this challenge we can overcome, ma'am, using AI?
Yeah, you have, you know, it's, looks like in this case, yeah. So sometimes cysts or what's called as abscess and infection also can cause high temperature. And so what we have seen is that a cyst or an infection is more rounded in nature. That is, it's not that irregular as cancer is, right? So if you remember, I talked about the hotspot boundary and speculations in the boundary. That feature is able to in most cases, there can be atypical cases like fibroadenoma, atypical fibroadenoma may be there and so on. So there may be atypical cases, but a smoother boundary means it's probably just a cyst. Sometimes an inflammation like an abscess can have such a high spike in temperature that yes, it can come out as false positive. However, that lady requires to go to a gynecologist, because then the gynec will or radiologist will put a small needle in, like take out the pus, right? So basically, as long as you're not messaging saying that we're saying that she requests a follow-up test. We're not saying she has cancer or whatever. Though the classification is about that, what it means when scores are high also is that there is another abnormality. For example, in JJMMC Davangere, when they did this, they do the screening for garment workers, and they found a case which was clearly so that's called BIRAD scoring in breast health, and so it was BIRAD 5, which is like high chances. And then when biopsy was done, it was found it was a breast TB, tuberculosis, and the doctors were shocked. They never knew how to actually find a TB in the breast. And of course, she's going to the medication 9 months and she'll all be fine and so on, right? And there is no way to detect that because there's no palpable, there's no lump for this as well. So yes, there can be false positives, like a very active cyst or an infected cyst can come out as positive, but the idea is to help people go for a follow-up test so that, they can right treatment. So right after this test, we say go for an ultrasound. Gives the tissue differences, and it can make out between cyst and a actual malignant lesion. Now, to your other question about why does some biopsy says no on surgery, there are two types. I'm not again an expert in oncology, but whatever I've learned, working with my friends, radiologist friends, and all that, is that first, usually they try to make it less invasive. So they basically have a poking of a needle, small needle poke, like an injection, which is called a fine needle aspiration. FNAC is done to take some tissue out of the lump. Okay. Now, if it is positive, you know for sure it is positive. But if it is negative, you don't know whether it is negative. And if the radiologist is still suspecting there is a problem, but FNAC comes negative, why would it come negative? Because there will be a lump this much and you would have poked here. Maybe you should have poked here. We don't know, right? Where in this whole lump? It could be half cancerous, half not yet cancerous. So FNAC, if it is negative and the doctor still feels there is a problem, they may actually suggest for a biopsy, which is a surgical procedure, right? Small surgery procedure to remove some tissue from the thing. So that is where the second histopath may be required. And the advantage of thermal imaging and the AI that we've done is that we look at the whole breast, right? So we figure out where is the focal increase, and then if there is malignancy anywhere at all. So it's not based on, so for example, so many women have come with lumps. Having a lump is not cancerous, by the way. It's 60% of the lumps are completely harmless. So when we do the screening on the lumps, we can make out which lump is very active and which is not. We call it hot lump and warm lump, or no active or inactive lump. So that also gives a little bit of confidence in the lady and the doctor that, we have not missed any case. Otherwise, you will be thinking, I've still poked, maybe there is a problem. Now, when you have a holistic look at it with let's say, thermal imaging, we know that nowhere in the lump there is a problem, right? So that also is an additional advantage of this. Thanks for bringing that point to my mind. Any other question?
Ma'am, is this thermal imaging a replacement for mammogram in future?
Maybe if you ask me after 10 years, hopefully it will be replaced. I wish it will.
Yeah.
So mammography, of course, has, in the US, it is used in two forms. One is called screening mammography, another diagnostic mammography. For example, mammography has one advantage that it can tell the depth of the lesion. In our case, we are not able to say whether it's 2 centimeters below the skin or let's say closer to the chest wall. We are attempting to do that. We are doing some thermodynamics modeling of the breast and all that. We have a long way to go because there's no way of measuring the temperature inside the breast, So right now, so that is an issue. Having said that, so mammography as a diagnostic modality. What do you mean by screening? Diagnostic screening is something that one can undergo when there is a problem, either found in screening or found through symptoms. Then we actually send to diagnostic workup. That could be mammography, breast ultrasound, or MRI. Many things will be done simultaneously. So in that, as many imaging, I was mentioning, right, in the electromagnetic spectrum, if you come to know about different aspects of the tissue, then the treatment can be much more effective. So there, I guess it will still win. Of course, mammography has been around for a long time. It's difficult to replace. But definitely, many hospitals are using our solution as a replacement.
Thank you. How exactly the classification, whether it is benign or malignant tumor in detection of breast cancer using thermal images?
Yeah, so if you remember, I showed on a slide,
Yeah.
There, a bunch of features. So all those are after you find a hotspot. So we've had the first phase where we find a hotspot or a warm spot, that pipeline you saw, right? So if there is a hotspot or a warm spot, it is possibly a benign condition or a malignant condition. Otherwise, it's normal, right?
Okay.
So normal, benign. Benign means basically there's something abnormal, but it's not cancer. That is what is benign, right? So normal you can set aside, and benign can look at it by actually looking, at least in our case, we're looking closer at vascularity and looking closer at hotspots. Right? That's what we're doing. If you find any other newer signals later, we'll probably.
Okay.
Because none of this has been done before, right? And it's something that we are working on trying to sort of improve the accuracy and so on. So now, last year onwards, or maybe 2 years back itself, we got good accuracy. But now with 100% sensitivity, we are going all out because, that's at the end of the day, we want to help people. We're not here to make money or harm people, right? So accuracy is 100%. That's when we can actually go on the ground. That's what.
Great. Thank you, ma'am.
Any other questions?
I have no question, but I have just one remark to make. I'm Pradeep speaking. It's just I want to tell our college community and the people who are here, the audience. Here is one instance where she saw a problem around herself and decided to solve. That is what I appreciate most in Dr. Geetha Manjunath's lecture and philosophy. This is what I've been trying to tell our college, our community in general. Look at problems around you. Try solving it. You can go really far. Thank you, Geetha, for a wonderful overview of the subject. Thank you again.
Thanks, Dr.
Hello, ma'am. Good afternoon, ma'am. Ma'am, please, can you, if possible, can you share your mail ID, ma'am, if possible?
Yeah, I'm Geetha@niramai.com.
Ma'am, we have one question from audience. There is chat. So what is the cost of testing? Dr. Veena Patil, she's asking, what is the cost of testing?
Actually, it depends on the provider. So we provide the solution to the hospitals. So hospitals, because they have to kind of, they have to get people and so on. So 3,000 rupees, 3,500 rupees is mammography. They charge 1/3 as like 1,500 per person. When we go to villages and so on, we have just a triaging where the doctors are also not involved. So at volume, and if the machine is all, for example, a cancer society can buy the machine because machine is not made by us. They have to buy, and if that is the case, 100 rupees per person.
Is it possible to run a camp in our region? Because our
I will be very happy to run a camp at your place.
Okay, that will be nice. Thank you. I'll work
now,
on
in fact, COVID has reduced the number of people going to the hospital.
Okay.
So we have started home screening also, in the sense like just like people will come, and you would have heard about diagnostic, blood and urine pickup from home, right? Similarly, we do first ever time, cancer screening is being done at home. We were covered by Europe media for that as well.
Yeah.
it's non-radiation based, right? If mammography, you can't take it home because a mammography machine requires a wall full of lead and all of that, right? Because it affects other people outside. Nobody should be inside. There you need radiation protection for all that.
For
Yeah,
hospitals to have an installation of this, how much it would cost?
we can discuss offline and figure out.
Okay. Yeah.
You can write my mail ID. I'll put my.
Ma'am, this is Girish. So, is there any opportunity for our students or any faculty who are interested in breast cancer analysis? Is there any opportunity in your company?
Yeah, if there is a strong, teacher who is going to stand up to make sure that there is a local guidance provided, because we can't do day-to-day guidance. So one of our data scientists can be working with them to give some problems that are of interest. Definitely. For example, in fashion, we partnered with IISc Professor Chirunji Bhattacharya. He was also very interested, so we partnered with them. And then for COVID, we we created a X-ray screening for COVID. Right, lung X-ray. Right. See, what's happening in villages is that COVID is a big problem, and people come with symptoms, and when they come to a primary healthcare center, they take the throat swabs. You know how this RT-PCR test is done, and then the throat swabs are sent to the district hospital or a lab somewhere there to actually do the test, right, to see whether somebody's positive or not. This whole process takes 2 days. By that time, a COVID patient with initial symptoms can go to almost like an ICU stage, right? And you're in the village or tier 2 cities, and you cannot wait for 2 days. So what the method that we adopted here, working with some doctors, is to actually many places have X-rays. So we said, why don't you take an X-ray? And so we have a WhatsApp group. It's called Swift, software for WhatsApp enabled something, fast imaging or something. So basically, the doctor just sends a WhatsApp of the image of the chest, the lung X-ray. Right? He takes a lung X-ray. It could be analog image or a digital image. He takes an image using his normal phone and does an WhatsApp to this particular group. And immediately our team puts it up into our interpretation server. And then we generate a report and send it back saying whether she's likely or he's likely COVID or not. This is not thermal. This is because people don't have thermal images everywhere, and so we send back the report. And if he or she is likely to be positive, she's immediately sent to the district hospital rather than waiting for the RT-PCR. And here again, we've got more than 88% sensitivity working with IISc. This is a joint work. So like that, we actually don't need to solve exactly the same problem with thermal or whatever. I mean, we could, but we really need somebody who's interested in solving the problem. So that's important, and happy to collaborate. For example, thermal imaging and AI can be used for several other type of cancers, other type of abnormalities, right? And we are a very small team to solve all of these issues, right? So if you pick a particular thing, like Dr. Pradeep said, if you feel for the problem, right? And if you feel for the problem, you'll find a way to solve it. So that's very, very important. So if you feel for a problem, you can do this and come back.
Thank you, madam. Any questions? I think no questions from participants.
Okay.
Thank you so much, ma'am.
And wonderful interaction. Thank you.
Okay. I thank Pradeep sir in helping us coordinating this session. Also, I thank Dr. Suresh sir, Principal, CIT-Open, and Shantla madam and Sridhar sir in helping us to organize the webinar. And it's really very informative, madam. Thank you so much for giving your time and giving this session. So,
thank you. Have a great day.
Thank you, ma'am.